Use and implementation of CAM ICU, a quality improvement project. In the National Confidential Inquiry into Patient Outcome and Death on Rehab Following Critical Illness, it was identified that recognition and treatment of ICU delirium is a key area for intervention. Increasingly, patients admitted to critical care are more likely to survive to hospital discharge. But these patients are often older, have chronic comorbidities, and are often left with significant physical, psychological, and cognitive morbidity, collectively termed post-intensive care syndrome. Recovery can take months or even years. Delirium is common, affecting up to 70% of patients who require mechanical ventilation and associated with long-term cognitive impairment. Critically ill patients frequently experience nutritional morbidity on discharge and need expert laryngeal management due to impact of artificial airways affecting swallowing, secretion management, and communication. The duration of delirium in ICU is one of the strongest independent predictors of death, length of stay in the hospital, cost of care, and long-term cognitive impairment. The ABCDEF bundle elements include delirium, assessment, prevention, and management in D. Delirium is a disturbance of consciousness characterized by an acute onset and fluctuating course of inattention, accompanied by either a change in cognition or a perceptual disturbance. You can have hyperactive, hypoactive, and mixed. We all recognize hyperactive delirium, but hypoactive and mixed are more common and have a worse prognosis, being missed in 75% of circumstances in the absence of active monitoring. And hence, as per critical care guidelines, SCCM guidelines, we need to adopt delirium monitoring, and the CAM ICU and the ICD-SC are the two most valid and reliable delirium monitoring tools in adult ICU. This aspect of CAM ICU is finding the RAS score of the patient. If it's anything other than 0, patient scores a point. One cannot assess a patient in deep coma 4 or 5 and would try to lessen the sedation to be able to assess. Feature 1 is then to look for an acute onset of fluctuating course in the past 24 hours. Has the patient had any fluctuation in the mental status, as evidenced by the RAS, GCS, or a previous delirium assessment? To summarize, feature 1 is in the past 24 hours, has there been a change from the baseline mental status? And feature 3 is there currently an altered level of consciousness? Once you have both of these features, you only need one more feature to diagnose delirium, which is inattention. Say to the patient, I'm going to read you a series of 10 letters, and whenever you hear the letter A, indicated by squeezing my hand, you then read letters from a following list in a normal tone, 3 seconds apart. Save heart. S A V E A H A R T. Errors are counted when the patient fails to squeeze on the letter A or squeezes on any letter other than A. If there are more than 2 errors, the patient scores a point. When this cannot be done, one proceeds to pictures, but to keep it simple, we won't discuss that here. There is a fourth feature that one can assess if the patient does have a RAS of 0, disorganized thinking, with a series of 4 questions which you can see on the slides. Again, in the vast majority of patients, one does not need to proceed to feature 4. Slides summarize feature 1, acute change or fluctuating mental course, feature 2, inattention, and then either feature 3 or feature 4. Feature 3 being altered level of consciousness, the first we discussed, and feature 4 being disorganized thinking. This quality improvement project Location in daily rounds of delirium and documentation of the same. Then providing education at the bedside to the doctors, to the nurses, to the OTs with a multidisciplinary team, creating a CAM ICU checklist. We had 2, 3, 4 iterations and re-audits with changes made in between each time. First time, a "This is me" leaflet to help increase awareness of delirium and hence monitoring and intervention. The key thing for doctors and nurses is to know that once delirium is detected, there's a range of interventions that can be done, and so their efforts and work is not wasted. This was highlighted through a patient information leaflet, which talks about interventions that families can do, and a virtual delirium toolbox, which with one of our OTs will deliver to each and every patient who has been detected with delirium. There's a doctor's information leaflet we created, which also will be used as a referral pathway once delirium is detected on a CAM ICU delirium positive patient. Non-pharmacological methods include bringing loose, comfortable clothing, hearing aids, glasses, familiar music, photos of close family and friends, familiar items from home, such as own blankets, a diary to keep notes of daily activities, reminding patients of where they are, holding their hand, reassuring them they're safe, discussing events that have happened recently or are due to occur, with more information on a QR code provided on these leaflets to families. For doctors, stopping unnecessary delirium-inducing agents that may impair brain function, such as unnecessary benzodiazepines, treating hypoxemia. If required, giving some pharmacological treatment such as haloperidol for hyperactive features, treating infection, sepsis, helping with immobilization, allowing patients to walk around if possible. Assessment is fast. 90% of RAS CMICU assessments take less than a minute. You can tailor the exam, not having to do every CAM ICU feature if you get your answers by a briefer exam sooner. Starting with features 1 and 3. Feature 1 is comparing patients to their baseline mental status, and feature 3 is about their level of consciousness right now. And since many ICUs repeat sedation scale assessments, these data are readily available. A quick mantra: is the patient at his or her baseline or fluctuating, plus RAS now, plus inattention test? Feature 2, inattention, is a cardinal feature and must be present to diagnose delirium. It's quick and simple. 95% of evaluations are done using only hand squeezes on correct letters or numbers to save heart and not needing the picture screen. The key take-home points of this presentation. 1. Hypoactive delirium will be missed if not screened for daily using a tool such as CAM ICU. 2. If detected, there is a range of interventions from non-pharmacological to medical that the whole MDT team can initiate once this is found. 3. Here at our ICU, we can flag up all hypoactive delirium patients to the MDT and delirium champions for each member of the MDT, and that team and the whole MDT can initiate measures as outlined to help these patients and improve their outcome. Thank you for listening to this presentation and Quality Improvement Project.